Top Med Talk.
Nick Majerison here. Welcome to Top Med Talk. This piece is taken from the Perioperative Medicine Shared Interest Group's 2018 annual conference, Measuring, Managing and Minimising Risk, which was held in association with the Australian and New Zealand Society of Geriatric Medicine and the Internal Medicine Society of Australia and New Zealand. Don't forget to check out the show notes on topmedtalk.com for more details. Have a listen.
It's my pleasure to next invite Professor Michael Cox, who's the Professor of Surgery at Nepean Hospital, where together with Professor Chris Martin, he established the upper gastrointestinal unit. During the last 24 years, the unit has developed a strong clinical practice in upper GI surgery and interventional upper GI endoscopy that now has 6 consultant surgeons. He also introduced the acute surgical unit in 2006.
Thanks very much. I've got a couple of disclosures. Firstly, I am Michael Cox. This is the picture that was in your program. I look a little bit different to that today. The reason for that is my son and I last Saturday went in the world's greatest shave, and that's the end result. I'm the one on the left. Disclosure number 2, I'm a general surgeon, and for me, the original title of this was emergency surgery, but I've changed it to emergency laparotomy, and as the previous speaker has already said, that's really where the money is. 30-day mortality ranges, as we've already heard, between 15 and 30% if you're over 70. And most of the risk assessment, which is what some of this talk is about, literature really refers to emergency laparotomy. So why bother? Early detection of high-risk patients, we've already heard a little bit about that, and I'll go through that a little bit more. Some of it is to actually get people thinking what is a high-risk patient to start with. Optimise physiology, well, I think everybody is aware of that and does that even with the low-risk patients. So I'm not so sure that that's important. We heard earlier about prehabilitation and various things you can do in elective surgery. The nature of emergency laparotomy means you just don't have the time. But you can direct decision making. And you can also make significant changes to the target care, both in terms of consultant assessment, consultant care, as in the consultant actually being there, particularly after 6 o'clock, where at least in some hospitals the registrars and fellows' competency seems to improve after 6 o'clock. Shared decision making, and I'll make some comments about post-operative ICU as well. There's a number of predictors that we can use. P-POSSUM is the one that's probably had the most written about it. It's the Portsmouth Modified Physiological Operative Severity, and it's a great way they got the U in there, of enumeration of mortality and morbidity. So at the end of the day, you have a risk of your mortality and a risk of your morbidity. And that's something that you can then present to patients and families. I won't go through each of these points, but just to remind people, it's got 2 main components: there's the physiology and the operative. It does have a couple of problems. Its area under the curve is not too bad. It overpredicts mortality in low-risk patients, but if you take low risk of mortality less than 5%, that doesn't really matter, and you'll see why in a few minutes. The real problem is that there is no frailty measure in this at all, and so it is actually a very poor predictor in the group that probably needs the most attention, and that's the elderly. It's post-operative and not pre-operative, although you can cheat a little bit and sort of, extrapolate what you might think is going to happen. But despite its problems, it's a fairly good predictor, and it was certainly the one used by Neela, which we've already heard a fair bit about from Carol. ASA grade can be used and is frequently used by anaesthetists in terms of their assessment of patients. The problem in terms of predicting the mortality with that is that you don't end up with a percentage mortality risk or graphics or anything else that you can present to patients in family. You can say, oh, he's high risk, oh, I think this is high risk. Again, it's repeatedly been demonstrated not to be very effective in the elderly, and there's one huge problem, and that is the interpretation of systemic disease is very subjective. One person's severe systemic disease is not necessarily the next person, and there's really no physiology assessment. So as you can see, I'm not all that keen on ASA. My apology, I know most of you are anaesthetists. Apache 2 is great for a research tool. It was designed to really look at initially at ICU critical care patients and trauma patients, and it made sure that you're comparing an apple with an apple. It used to be criticised because of the data points, and it was a little bit complex for simpletons like me, but you can now get an app on your phone. Once again, though, it doesn't really define or give you a percentage risk, and you don't get any graphics that you can show family and patients. But for a research tool, it's really useful. The Nesquik Calculator, and as you heard in the previous talks, I'm a bit of a fan of this. We're one of the first hospitals in Australia to introduce Nesquik. I would strongly recommend all of you to go and look at Nesquik and try and convince your surgeons to use it. It's available online. The calculator is available online. It is actually very, very good for elective surgery, as most of the data, and it's now over 12 million patients in the database, a lot of it is actually elective. It gives you some really good morbidity and mortality graphics, so you can have somebody coming along, that 80-year-old that was in this morning, earlier on today, with the colorectal cancer. You can sit down with them and say, well, here's average, okay, 1% risk. Here you are, 14%. But here's your risk of wound infections. Here's your risk of not getting back to normal activities. This is where you might be in 12 months' time. And it's really quite good graphics, and the printout is actually quite powerful tool. Its problems, it significantly over-predicts mortality in emergency surgery. We did a study at our hospital just to sort of run through over a few months, and it's around about 2 to 3 times, and the older the patient, the higher the gets. The other comment I'd make, if you're going to use it, beware of the nursing home. The nursing home definition here is somebody that goes to nursing care post-discharge, not a nursing home as we understand it in Australia. So you need to be a little bit careful with that. I've taken to getting a black texter and crossing it out so the patients don't see it, because it sort of overestimate or sort of gets misconstrued. Kneeler. We've already heard about Kneeler, and I'm a bit of a Kneeler fan. It was established in 2014. We've heard some of the history already. Uses peak possum. And the key component was dividing it into 3 categories. Low risk, less than 5% mortality. Now, when you first hear this, you think 5%, they're calling that low risk. I would have thought that's pretty high. Intermediate, which was 5 to 10, and then high, being greater than 10%. And then just doing process audits. CT scans, antibiotics, we've already heard about this. I think the 2 important things were the staffing levels or grades based on mortality risk. So if you had a greater than 5% chance of mortality, the audit was to have a consultant surgeon and an anaesthetist there, even after 6 o'clock. And there was also targeted care. So if it was a 10% risk, you needed to see the consultant within 4 hours. Now, that was music to my ear. As you've already heard, we established the acute surgical unit, which is a consultant-led surgical unit at Nepean 12 years ago. So I thought that was fantastic. The other thing is the mandating of an ICU admission if your risk is over 10%, not review and recovery. Okay, improved outcomes we've already heard. It's not quite less than 9%, but I've been told, I've hopefully not let the cat out of the bag, reliably told by a couple of friends in the UK that it's actually is much, much better in the latest reports, certainly less than 10%. Morbidity is also improving. There's an expected reduction in futile surgery, and now I've put that in inverted commas because futile surgery I'll talk about in a minute. It is actually really hard to define what people mean by that. I think two of the biggest changes, and we've just heard another one that I should have had on the slide. One is that there's been significant improved funding and resourcing of emergency surgery, particularly emergency laparotomy. Ruby is no longer sitting around in a hospital bed in the UK for 3 days getting bumped. There is now the facilities and the capacity to look after her as she should be looked after. The use of a better tool for prediction, and that's the NELA tool, which I'll talk about in a minute. And finally, the change in culture that has undoubtedly occurred within the NHS hospital, looking towards emergency laparotomy. And I know that's a hope that will also occur in this country and across the ditch. So the NELA calculator. It was developed from NELA data. It is therefore emergency laparotomy specific. It does include frailty, and it's certainly been shown to be more accurate than P-possum. It still needs to go through validation studies, but I think this is the way to go personally. And you can, as you can see from the picture, you can download it onto your phone. NZELA, Ben's going to talk about that, and I know those that were here at the workshop this morning have already heard James talk about it, so I'll leave that to them. Okay, so which tool should we be using for risk prediction? Personally, I think NELA is probably the best because it is for emergency laparotomy specific, but we need to wait for a little bit longer for the comparisons and the validations to occur. Does it really matter? Well, I don't think it does all that much, whether you use NELA, P-possum or even Nesquik, as long as you're using something and routinely assessing your patient's risks, then acting upon it. It's a little bit like having Nesquik data in your hospital. There's no point getting the data if you don't then change what you do. So my utopia with this data would be shared decision making. Many people in the room have had to put up with us surgeons ringing you up saying, got a lady with a bowel obstruction. She's not too bad. She's 82. She's got diabetes. Oh, yeah, she had CAGs and stuff. But, yeah, she's not too bad. What the shared decision needs to be clearly between the surgeon and the anaesthetist, but there's two other key components. One is the intensivists, because if it's going to be mortality over 10%, risk over 10%, they're going to go to ICU. And probably the most important person is actually the geriatrician. If the patient's over 65 or if they have a geriatric syndrome. Working where I come from, we have an awful lot of 55-year-olds that are geriatric. The decision-making may be yes, no. Now, this is really easy with elective surgery where you've got 2 or 3 weeks lead time and you can have multiple meetings with patients and family where you can wait for the daughter to arrive from 500 kilometres away. It is a huge problem with emergency surgery when sometimes we really only have 2, 4, 6 hours to really make that decision. So I think where you can still use it to discuss mortality, morbidity and recovery, but where I think it becomes even more important is if you do decide yes, is repeating that discussion with the data, with the risks, and defining limitations of care afterwards. Now, the reason for having a geriatrician there is that they're much better at finding out what are the patient's care goals. Surgeons are historically terrible at it. I'm a little bit educated in this, but I think I'm still nowhere near as good as a geriatrician. The next thing you do is your resource allocation. So the where, whys, whens and so forth. So if you've got a 5 to 10%, you have a shared decision. But you also have a consultant surgeon doing an assessment as well as a consultant anaesthetist present at the surgery. And as I repeatedly say, even after 6. They also then go to a high-level nursing care afterwards. Now, depending on the institution, it might be a COB bed, it might be a high dependency, it might be an ICU room where you have shared ICU high dependency type care. The high-risk patients greater than 10% are assessed within 4 hours and they must have shared decision. More importantly, they do not have the review in recovery. They mandatory should be going to ICU. The data is unbelievably clear. And you should also be, if limitations of care have not been able to be established preoperatively or prior to admission, certainly establish them in that care. What about futile surgery? Well, futile surgery is really, really easy to define. I didn't quote the paper that this came from, but if you're over 90 years, if you're ASA 5, you're in septic shock, your dependent status, having coming from a nursing home, surprise, surprise, you've got a greater than 90% mortality. So that's futile. Okay, right. That's what futile surgery is. We can go home. The problem is that there's a bit of a prevailing attitude, both within our community and also amongst various caregivers in our hospitals. And that is that we shouldn't give up. This is how I feel about futile surgery when I have to give a talk about it, and I think it is a really difficult topic. Part of it is that there's a huge variation in what we consider futile. Some of you as anaesthetists may consider a mortality of greater than 10% futile and a 50% mortality at 6 months futile. I'm not going to argue with you, but other people wouldn't see that as a problem. Whereas other people would see, it's 100% mortality if we don't operate, 50% mortality at 6 months. Well, the other 50% are all right. Then somebody else will say, yeah, but they're in a nursing home. So it's really difficult to define futile surgery. And there's a huge emotional input, both from the caregivers, but also from the families. But he's my dad. So one approach is the individualised approach, and this is really where the geriatrician comes into it a lot. We can take two famous quotes. So my old mate Mahatma, everything we do is futile. Sounds a little bit like a quotation from Ecclesiastes in the Bible, doesn't it? But we must do it anyway. But I think this is probably where the geriatricians get it right. I fear vastly more a futile, incompetent old age than any form of death. And that's using the NELA risk, having a joint MDT approach with the geriatrician, because they can actually find out and understand that concept of goal-directed care, and they can educate the other 2-3 components better and can provide the data for the family and then determine what the goals of care. As I've already said, this is a little bit difficult in emergency surgery because you've got time pressure, but certainly in elective surgery it's useful. So thanks. The reason that James and I look like this is actually because of this. This is my youngest daughter and her fiancé. They were to be married 2 weeks ago. Unfortunately, Connor's still in Westmead Hospital with acute undifferentiated leukaemia. He gets a great deal of support from the Leukaemia Foundation, hence my change in appearance. Thank you.
Lee Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.